Okay. Yeah, so I had to smile when I saw this message, and it's like, okay, well, some of these things are still getting out there, and I always like to inspire young and upcoming physicians, because
I
I
love
think,
that.
yeah, because some people are looking for inspiration, and the way things are, sometimes just the bad gets highlighted, and then the fun, good parts just kind of get buried. So yeah, I said, oh well, I can talk to this young lady, and if I can inspire her to do this if you want to, or maybe you might not want to, because I know you said something about radiology. So yeah, I'll let you do the talking and I'll answer.
Yeah, thank you. I appreciate it.
Yeah.
So I'm a third year now. I'm doing rotations, and I had internal medicine, and I'm actually on emergency medicine now, which I'm also liking a lot more than I anticipated. But really, I've always been interested in infectious diseases. I did research before med school. A lot of it
Mm-hmm.
was in ID, and I always thought that's what I would be going into.
Yeah.
But then after my medicine rotation, I just started to wonder. And I think also it's been hard to get an idea of what ID is really like in clinical practice, and
Mm-hmm.
especially in settings that aren't just at the academic hospital, because
Exactly.
that's all that I've seen, and I know there's more out there, and
Exactly.
it's just hard to find. So
Exactly.
I think I don't remember exactly how I found you. I think I was just Googling like ID,
Mm-hmm.
physician, outpatient, day in the life, just trying to
Yes.
figure it out. And you came up, and I
Yes.
thought, that's great. So
Yes.
I have a ton of questions,
Sure.
but primarily would just love to hear like what your career trajectory has been like, what your practice looks like now,
Yeah.
what you think of the field.
Yeah. 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 So I've graduated from medical school in 2001. So it's been 20 years, 20 and a half, 20 years last summer. And I always like medicine. You go through phases like you're probably experiencing now from the time you're in medical school and even just beyond, where you're like, okay, I want to be a pediatrician. And you're like, no, that's too sad when you're in internship, you realize children, sick children. And then, anyway, throughout the course of time, like I just felt that I always kind of like public health in a way. And I'm from the Caribbean event originally. So I always had a belief that I would go back to the Caribbean. Like I'm from Antigua, so I always wanted to go back and just kind of help, contribute to medical care in the Caribbean. So then I found out, medical school for me, I trained at the University of the West Indies in Jamaica. That's our Caribbean medical school. And after that, realized that, okay, I could go and do internal medicine in the United States and get that first world experience. The idea was for me to get the first world experience and then kind of combine that experience with my Caribbean experience and then work back home in Antigua. So came up here in New York, did the internal medicine in New York at the teaching facility. And I was Harlem Hospital Center, one of the Columbia University affiliates. And then it was really good, inner city, good training, academic, exciting. And then only there I realized that infectious disease was a specialty. I didn't even know it existed as a specialty. And I thought that was pretty exciting. And that population in New York City was quite diverse. So we just saw everything, and so that really excited me. And I felt like it was something that would apply to the Caribbean, like the islands, kind of more tropical setting. And so I did that infectious disease fellowship at the University of Medicine and Dentistry in New Jersey. And that was another good, like really broad training, university medical center in the inner city. Then we had like a sort of like we had a VA as well. And then we had like a more high level kind of private facility, and then all the stem cell transplant cases and virology lab, which is not a very common thing anywhere, much less in the United States. So that really extensive training. And it was just so exciting, just all those types of people, from the veterans to the inner city people, and then to the, I guess kind of more upper class people, whatever, right? So it was just really exciting, very, very busy, but I didn't mind because I realized I wanted to get as much practice as possible. So I always liked medicine. I guess it was easy for me because growing up as a child, my parents always said I wanted to be a doctor. So there was no doubt. So I enjoyed everything because I just liked it. I wasn't forced to do it, I didn't do it just because like, status, or because my parents were that, so I have to do, some of the people have these kind of things, and so they're not happy, they're miserable. but I just wanted to do it, And so after I did all that, then I went back home to the Caribbean, and stayed there for about 2 years. But after all that experience, then to go back to a population of 100, like 90,000, you just don't really get to use that experience. And so I just got so bored. And so I applied and came back up to the United States. I was going to go crazy if I wasn't able to use that experience. Like I was hardly seeing anything. I was just doing HIV. And as much as I like HIV, I didn't want that to be the only thing I was doing. And so I just came back up to the United States and ended up in Mississippi just because, it's a place that is not a popular place. A lot of people want to come here because, it's like the South and rural, et cetera. But I think it was probably the best thing, to not be in one of those fast-paced places like New York or New Jersey. You come here and you're doing real medicine, and there's more autonomy. And I never wanted to be like in an academic kind of research setting. I don't like research, never liked research, papers, meetings. I want to be there with the patients, right? So I feel like a place like this, or sort of not an academic fast-paced city, but like a more rural town, I guess. Doesn't feel that rural, but anyway, this kind of place where you are doing real medicine, the people depending on you, real medicine, no frills, just real medicine. And so that's how I ended up here. And I've been here for 8.5 years, and I've totally loved it, right? But it's busy, like you saw in that post. I think you read the post where I outlined the day. And that was when life was really, really hectic, just before I had my son, he's about to be 5 in less than 2 weeks. So yeah, so it was just really hectic. It was exciting, but it was hectic at the same time. But because I didn't have my son, like it didn't feel that bad. Maybe it was stressful, but it wasn't terrible. Like I didn't feel guilty about ignoring somebody. So you saw like, I would have clinic and then because there's hardly anybody here in Mississippi, like you just kind of have to do everything. So I've been the only ID doctor here for the whole time I've been here, 8.5 years. And so I had to initially start kind of providing service for all the facilities here, like 4 facilities, but they're like a block apart. They're like in walking distance, right? So it was just me alone. So I would just have all these patients, often more than 30, to be honest, which is probably not the best thing, but I because I trained in busy centers, I learned how to be efficient, right? And then because I liked what I was doing, it wasn't like a massive burden. Because when you like what you're doing, like that makes life that much better. If you're just kind of going through the motions, then it's awful. So that whenever I see people, like young people, students who are thinking about medicine, I just tell them, like, just make sure you really want to do medicine, because a lot of people find it so hard to, after investing all that time and money, to then change their mind after. So it's such a big time and money commitment that you kind of have to make sure you like it, right? So so yeah, as busy as it is, because I have a love for it, and for me, the main thing in medicine is the fact that it's a people kind of thing. Just talking. The most fun part is just talking to patients. So I help train residents now. I've kind of moved away from that busy sort of thing to now I'm just in one facility, one hospital, one building really. And I do the infectious disease consults, and now I actually do some internal medicine. I help as a preceptor for family medicine residents on their inpatient hospitalist service. So I do hospitalist medicine, internal medicine, hospitalist, and help train these family medicine residents. And that's actually fun. That's a lot of fun. And then I do my little infectious disease separately, but because it's just one facility, it's not that hectic an ID practice. And I don't do clinic anymore. I had to give up clinic. Clinic just wore me out. So I don't do clinic anymore, so, but yeah, it's been 20 years plus. So for you, you're just starting out. It's not as, like for me, I feel like it's easier now because, you get more confidence as time goes by, right? And as you get more experience, obviously, you know more what you're doing. Right?
Yeah.
But I don't think it was ever hard, but it definitely gets easier.
Yeah. That's great to hear. Yeah. Wow. Yeah. So what was, I guess I'm thinking about like inpatient versus outpatient. What was clinic like? What kinds of patient? Was it like a lot of HIV, or did you see like a whole array of things?
Yeah. So I actually did happen to have a big HIV practice here, pretty big, pretty sizable, because I remember people in Jackson were surprised at how many I was seeing. So because again, we just don't have HIV providers. So there was none other for 90 miles. You had to go 90 miles to Jackson to get an HIV
Wow.
provider at the university or this other hospital. So so I was the only HIV provider, but then that was probably maybe less than 25%, I would say, of the practice. Yeah, it would have been less than 25%, I'm guessing, but probably. But then it's just a regular, here, this is the diabetes capital. So the diabetic foot infections, lots of those. The people who had bacteremias, bloodstream infections, severe bloodstream infections, who needed to continue antibiotics intravenously for a while after to make sure the infection is fully cured. So somebody would need to follow them, because now we do a lot of treatments outpatient rather than in the hospital. You know, as you probably know, there are these home health companies that help supervise them at home, and then they have to kind of follow with a physician. So it was always my responsibility to monitor them in the clinic setting to make sure everything was going well, and there was no complication and so on and so forth. So a lot of those, and then, you know, this sort of run-of-the-mill things like urinary tract infections and, you know, infections that people believe they had, and then I would have to kind of convince them that they didn't have it and explain to them why they didn't have it. And that kind of was the most stressful part, probably. Trying to tell people that you don't have this infection, you don't need this antibiotic. And so that was not fun.
Yeah, I
That was
can
not fun.
imagine.
Yeah. So, I mean, just kind of those things. And we would occasionally have something rare, you know, like a sort of unusual fungal infection. Nowadays, there's so many people on these immune suppressing medicines. So we would have cases of some unusual infections related to that. So actually here we saw things that university sent us see as well, you know, so
That's awesome.
yeah, it was good. It was good. Mhm. Yeah.
I think one of the things I was wondering, because my interest in ID is definitely more of the tropical medicine and like
Okay.
weird things, and I
Yes.
love the academic like diagnostic part when a
Mhm.
patient comes in and has like all these weird symptoms, and you have to figure out
Yeah.
what's going on.
Yeah.
But then in practice, when like a lot of like what you were saying about like the run of the mill things and how a
Mhm.
lot of it is
Mhm.
like diabetic foot infections. So
Yes.
that's what made me start wondering if like I would actually like ID in practice, or if
Yeah.
it's something I just like reading and learning about, and like
Yeah.
the crazy weird like question stems we get. So I think that was like a big source of my internal conflict and debate
Yes.
about whether I pursue this field or not.
Yes. You know, the rare kind of tropical exotic things, I would say in regular American cities, you would not really have too much of that, right? If you're in like a big sort of city or in a city where there are a lot of people from all over the world, then more likely than not. But here for me, I mean, I'm seeing Americans. I always joke that I'm probably the only foreigner around here. Well, there's some other non-Americans here too, but like, you know, like you just don't have that kind of population, people from South America and the African countries and so on. So we just do the regular things. But you actually, why I like ID, why I think ID is fun is that you actually do have to put on your detective hat for the simple infection, the so-called simple infections, for pneumonias, right? You might have a pneumonia patient who's having a high fever, you know, for 5 days, 102. They have a big old ugly infiltrate. There's no positive cultures anywhere on anything. And if you did not take the history from the patient that they came from a cruise and they stayed in a hotel that was locked down for 8 months because of COVID, right? And they were loopy, you know, confused, and some other whatever abnormalities, then you wouldn't think to test them for Legionella.
Yeah, I was
And
just
so as
thinking
much,
Legionella.
yes, as much as I probably hadn't seen a Legionella case since residency or fellowship rather, if I didn't put on my detective hat, because the woman, like, you know, fever so high and sick, you know, this is a healthy woman, right? Well, although she was diabetic, but her A1C was controlled, it was less than 7%. So if I didn't think, like, that's the fun thing about it, like, you know, like that's why I talked to you. I mean, I mentioned to you and I talked to my residents about getting to know the patient. Like, if I wasn't a nosy person, or if I wasn't interested in getting to know this person, right, and know that she loves to travel and she was so looking forward to traveling again after almost 2 years of no travel, and she went on this riverboat cruise and blah blah blah, right? I would never have diagnosed her with Legionella, right?
Yeah.
Now she probably would have gotten better because we probably somehow would have figured out, okay, let's put her on this antibiotic, and and then she would have eventually gotten better. But then the satisfaction of a diagnosis, nothing beats that, right?
Yeah.
So and then we have like Staph aureus, either methicillin resistant or methicillin sensitive. Staph aureus is like a massive, like one of the commonest things we deal with. But like you might have heard them say in medical school about tuberculosis, Staph aureus has protein clinical manifestations, right? So the spinal epidural abscesses, the psoas abscesses, all these deep abscesses, the endocarditis, so just recognizing, and even little things like thinking in your mind, okay, the person has Staph aureus in the urine, but Staph aureus usually doesn't cause UTI. So you better be thinking that, okay, I need to do a blood culture because it's probably in the blood, filtering in the urine. If I don't do a blood culture, then I'm going to miss the fact that there's prolonged bacteremia. The patient has an abscess that needs to be drained. They're going to end up with a spinal abscess. They're going to end up paralyzed, so just all that. So it's a simple kind of comment. It's not exotic, but it's exciting because it can cause anything. And you better pick up that spinal abscess so that your patient doesn't get paralyzed, And so we rush a lot. And in medicine, like, you always hear about, oh, doctors only have 5 minutes with a patient in the clinic, blah, 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 right? But I truly believe that there are ways to find time to be with patients and figure it out. And like, not all patients are going to need the 15 minutes or even the half an hour, right? So you can rush with those, but then you have to kind of know, and as time goes by, and just being curious and inquisitive with the patients, and then you should kind of just get to know like who you need to spend more time with, and just so on and so forth. Just being inquisitive and just dealing with it as a person to person, like this is a human being in front of you. And just like I always tell I refer to my residents, because I always tell them, like, just think about it as the person. Put down everything, put down the computer, the results, just remember it's that person in front of you. And what are you going to do for that individual? Because every individual will need like one person. Option A is good for this person, but bad for another person, right? And they will need option B, so just like getting to know each person and the specific situation and circumstances, and just kind of tailoring everything to them. And that's why it's fun, because it's never the same decision for each person. It's like a lot of fun. I'm a nerd. I'm a medicine nerd.
I love it. Yeah, a lot of what you're saying resonates with me, and is why I actually more recently kind of ruled out radiology. That was a recent consideration for me that like a friend kind of sold me on, because she's applying and is really excited about it. And I was feeling pretty burnt out from school and was like thinking of prioritizing more quality of life. But then I realized that for me, the whole point of medicine is the patients, and I couldn't do that. But that said, I also, whenever I mentioned ID to anyone, I'm sure you've heard this, and it's probably like a misconception. And I know it's most important to love what you do, but people will always say like, oh, ID docs are so overworked and underpaid and just like really poor quality of life. But I mean, you seem really happy and stuff, so that's really refreshing to see and inspiring.
Yeah, I think I like I said, I think you just have to, like you said, remember why you're doing it. And if you make it about the human being in front of you, if you make it about the individual, right? And I mean, it's easy to get pleasure in an individual being benefited in some way. So you might not always be able to cure somebody depending on what they have, or you might not always be able to make a specific diagnosis if it's something like, I don't know, rare or whatever. But like, it's just the like the human connection, right? That might take a while. Like you might meet somebody who is like so grumpy in the beginning, and they're like, but you just kind of continue to be human to them, and just like understand that maybe they're sick. Like, I don't know. There are reasons why people are grumpy, right? And like so many times, like day after day, and just somebody just eventually just warms up. I don't know. I just make it about the human, like the individual connection, rather than like numbers or like, I don't know, bodies. Because I think if it's just bodies and it's just like a thing and it's just numbers, and so it makes it more impersonal and more like, I don't know, a drag, right? So we are busy, right? And when you're busy, then you have to recognize when you have to pull back. So like that, for me, I did get to a point where I was really like getting burnt out after my son was born, and then I was just covering all these facilities. And then sometimes you feel like, oh, it's just you, and they kind of need you, and your patients have gotten used to you after 4 years, and you feel bad about leaving. But then when you think about it, and you just have to realize that you can't serve people if you yourself are like tired and worn out. And so you just have to always like remember, like if you're going to do and serve people, like you have to take care of yourself, so it's hard decisions, but you just have to be strong enough to make the hard decisions. So it was tough. Like my nurse was sad and crying, and the patients were crying, and like it was like a disaster, and they wanted to cry. But like you feel bad, but like you just have to, you're not giving up altogether, but you're just kind of pulling back a bit so you can continue to serve whoever you can. And like so burnout can happen. But and then my colleagues, like some of the other physicians, females particularly, and that's what made me realize that a lot of times doctors, maybe female doctors, are just afraid to do something for themselves. Like they feel like, I don't know, they were like, oh wow, you closed clinic, you stopped doing clinic, you're only doing inpatient, oh wow, good for you. And it's like you feel like they wish they could do that too, but they feel like they can't, right? So I know, like I don't know, maybe because I've been a doctor for 21 years now almost. So I guess it gets easier to get better. And then another thing as well is that I think it's important for young people like you coming up, like to establish yourself as a person who has high standards, because high standards are so rare right now. Like there's just so much mediocrity. Okay. And so, like if you actually have high standards, then you stand out. And so if you stand out, then you're a little more likely maybe to get what you want, or because like people know you're not just some sort of mediocre person just doing anything and going with the flow, right? So they would actually try to accommodate you. You'd be accommodated more, right? Because they're like, oh my goodness, this person has high standards, like we need to keep this person. Okay. Yeah. So I think that's like an important thing for young people. And I again try to tell the residents, like, just establish yourself from the beginning as somebody who has high standards, somebody who works hard, because it takes hard work, and it does take, maybe a little less sleep sometimes, depending on specific goals that you have to achieve, like you early on with your exams and so on. Like you have to work hard. Like you're not going to get anything big without working hard. That's just a fact. Okay. And so establishing yourself from the beginning as somebody with super high standards, you'll never have a problem getting a reference, right? You'll certainly never have a problem getting a job. And whenever you leave your jobs, everybody will cry. Like and then, like literally, and I'm not like bragging, but I'm just saying that, every time I've moved from, like, well, not that much, like the university, when I left Jamaica, I left Antigua, my country. And then when I scaled on my clinic and so on, like have such high standards that people don't want to see you go. And then they try to accommodate you with whatever other perks, maybe to see if you will stay. You might not always stay because of whatever, you just have to kind of progress and move on. But high standards, like I would encourage you to establish yourself as somebody who maintains super high standards. You pay attention to detail, and you just do whatever you have to do. You don't cut corners, you don't take shortcuts, because that is just so common.
Yeah, definitely.
Yeah.
Very important. So what's your schedule like now?
So now, and this year is another year where I'm like, you know what, I'm going to scale down a little more. Because my son is going to be 5. I only have 1 child, but I don't know. I know some people have 3 and 4 and 5 children, but I don't know. I have 1 son, and he just keeps me busy. And, I'm like, I'm 43, right? So I'm not like the youngest parent. So I feel like I need to spend more time focusing, maybe on family kind of, and not as, not like put all my time to work, and not have that time for my son while he's growing up. So now I do 7-day stretches on average, on call with, and that's hospitalist service. So I have the residents, And then whatever infectious disease consults, I do those as well. But with the residents, that's internal medicine, generally speaking, hospitalists. And so morning, 7:30, 8 o'clock, whatever. It's like I'm here the whole day and that do that 7-day stretch. Yeah, plus or minus. And then I used to come back to work the following week and just do infectious disease in between and do those 1 week, 7-day stretches once per month. So now, I don't know, it's maybe every other week. It just depends on the schedule and work. But now I'm probably going to take off the weeks that I don't have to do those 7-day stretches, and just kind of have that extra time. I do more stuff online now. I decided a year and a half ago where I was going to try and sort of have an online presence, kind of focusing on health, maintaining health, promoting health. It's just people, I know a lot of people want to improve their health, but there's just so much confusion about just what to do, diet and lifestyle modification. We use that loosely. Oh, diet and lifestyle modification for improved diabetes control, heart failure control, hypertension control. And people, it's like, oh, exercise, eat well. What does that mean? So there's a lot of confusion about that. And because here's the diabetes capital of the world, I've thought for so long, what can I do to help, improve, people's diet or awareness with respect to diabetes and so on. And so I do more of that in my free time, just online presence, kind of teaching and sensitizing people to food and the importance of food and, improving your food to achieve health, because there's just too much medication. It's like the society is over medicated. So whatever I can do to help people realize that they actually have the power to improve their health to an extent with food, making healthier, better food choices, then I'm doing more of that, and some online coaching as well to help people actually get off sugar, break up with sugar, as I like to call it. So I do. Yeah, that's kind of it. So now I'm here at work still, 5:30 in my time. I've been here since about 8 o'clock this morning, and I'll be here another hour maybe. We've seen, I just rounded, I don't think we have any more patients, or maybe we do, I don't know. But to any more admissions. So yeah.
How late do you usually stay?
Well, up until last year, up until December, it was some, 7, some occasionally 8 o'clock. I don't want to say, but yeah, sometimes 7 to 8, because I actually don't stop because I was like, I need to take my son to school. Like I need to prepare him. And I guess because I've, you just kind of, I've worked really hard for the past 20 years and, you just kind of make priorities. And because I know I'm going to do my work, I think people around me for the most part know that I'm going to do what I have to do. So I have some flexibility and I'm actually grateful for that, but I think I earned it. And
Definitely.
So I come, I take my son to school for 8 o'clock, and so I start my day at about 8 o'clock, but I have support, the residents and nurse practitioners and so on. But then I stay and finish what I have to do. And so sometimes it goes until 7, sometimes it goes until 8, but I get it done, and I get it done with high standards, I believe. Yeah.
Definitely. Yeah, those are long days.
They are, which is why now I'm like, you know what, I'm going to just kind of take, not come to the hospital on those weeks, most of the time that I'm not on call. Yeah.
Mm-hmm. Do you know of, is it uncommon or common of ID docs to work, like, I don't know, is part-time everything, like 4 days a week? Or
I believe so. I think in the past I've seen job opportunities like that where people work part-time. You have to be careful, because I know this was the ID, but somebody was talking about how they were meant to work part-time, but it ended up being, it was 3 half days, but ended up being 3 full days or something like that. So but yeah, and then actually I do know now as well that there's this whole thing in a hospitalist, kind of infectious disease hospitalist, where I think some internal medicine hospitalist groups would hire an infectious disease doctor, and so the ID doctor would work on that 7 on, 7 off schedule, so 7 days straight in the hospital, and then they have 7 days off. So that's getting more popular, right? Not everybody likes it because, like you said, those are pretty long days. I guess that's almost what I'm doing, right now. But there's that. And then if it's part-time, if you're clinic, there's some clinic practices. Once I'd spoken to practice, and I think, it was just outpatient, because some practices you can get a job with, it's just outpatient. But it depends on what you like. I personally like inpatient. Like because I take so long with some patients. So in the clinic, you have people waiting on you, and people would get mad with me, which is one of the reasons why I had to give up clinic, because I just didn't want to keep people waiting anymore and have people being upset, they're waiting too long and so on. And so in the hospital, they're in the bed, they're not going anywhere. So
Yeah.
you can go, yeah, so you can take as long as you want with one, and then you can, there's some that quick, and nobody's waiting on you, nobody's getting angry. So I personally love inpatient medicine. You just come, you do whatever, you handle, the families are there whenever, I love inpatient. I don't like clinic at all. I don't think I'll ever do clinic again. Yeah.
I think I'm the same way. Yeah. I was surprised that I prefer inpatient much more
Yeah.
to clinic. Clinic is
Oh,
just
yeah.
like boom, 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 boom.
Yeah. Clinic, they're on appointment, and you have to keep the time, and you just cannot keep in a slot. Like, especially something like Infectious Diseases. Sometimes people would bring you these big stacks of records for you to review, and you're just like trying to review, and it's just impossible. It's impossible. Yeah. So I think for me and what I like and my lifestyle, inpatient medicine is just inpatient infections is 100% better. And then there's the acuity as well. Like, it's more like, you get that acute care, and then you see, and you have immediate improvements depending on what it is, the death first and so on. And then, of course, then we outline a good plan to go and be followed up by there, because we don't have outpatient ID now, which is unfortunate, but then I have the responsibility to outline a really detailed plan so that whoever is following them, their primary care provider, can do whatever they have to do. So yeah. Mm-hmm.
That's great. Yeah.
So when are you going to be applying? Oh, well, you have to do in residency first. So you have to, what you're trying to decide is whether to do internal medicine or radiology, or I don't know, whatever.
Yeah, except now radiology is out. So now I'm actually deciding between internal medicine, so I could do ID, or now emergency medicine, which I was surprised to find that I liked. I thought it would feel rushed, having these quick encounters. But I really like that it's intense when you're on and you work really hard, but then you're on and then you're off when you're off. And I like that division.
Yes.
And then I like that I've been seeing a lot of infections in the ED, and I feel like that's actually the primary workup. And for me, the diagnostic workup is always like the most exciting part. And I like that more than like what I was doing inpatient of like taking medications and up and down and looking at labs and stuff. So I don't know.
Yeah. What about the fact that in the emergency room, you don't really get to develop a very long relationship? I mean, I'm just asking you to think about it. I mean, it might be okay with you. And obviously, people visiting the emergency room do need somebody who's at least going to pay attention to them, even if it's only for half an hour. But I mean, what about that for you? Like,
Yeah, that's a big downside that I think about a lot. So I don't know. So do you have that kind of long-term follow-up with patients that you see inpatient if you're not doing clinic?
Well, because this facility I'm at, they happen to have also a long-term acute care facility. So how, there's the acute care hospital now, everything is so fragmented. There's long-term acute care, so somebody who might need antibiotics and or wound care or on the ventilator for like weeks and weeks. So they can't go home, they can't go to a nursing home. They need still acute care, but for prolonged periods. So we have that long-term acute care facility here. And so I'm a part, a lot of my patients are in that facility as well. So I get to see them, like my infectious disease patients. So they will be in the acute hospital. We establish what they have, and they need antibiotic treatment for this long. They have bone infection, a bad wound, etc. And so they're down here. So that's one of the good things. Actually, it's been really good for me here. I've been able to learn even more, because just being able to see people for weeks, on the inpatient center and observe things that happen. Like today, seeing somebody who he had a staph aureus bacteremia, bad infection, came from his knee joint, or it went into his knee joint. It was prolonged. Anyway, the poor fella is just about to finish his 6-week course of the antibiotic infusion, the drip, tomorrow, right? But then, you over the course of time for elderly people, you see, okay, you start with this thing, and then you have complications. You have gross hematuria, like several days bleeding in the urine. You have to figure that out. And now this knee infection and the bloodstream infection is almost done, but now the poor fella has developed shingles. Right? So this rash, and they're like, oh, he has a rash and so on. So I'm like, oh yeah, that is definitely shingles. So just simple things like, well, not simple, but just things like that you get to see. Like if he wasn't here, And probably I should get the residents to come look at that tomorrow. Actually, that reminds me. But yeah, like you get to see something like shingles, a dermatoma rash, right? Just things like that. Some people might develop like a herpes, like a bad oral, like stomatitis, and you have to be astute to know, okay, it's not a bad yeast infection in the mouth. It's actually viral, and you need a much different medicine. So just that kind of thing. So I do get to see them and develop relationships, the spouses, the children, and so on. Yeah.
Yeah.
And then unfortunately, we get people coming back sometimes kind of, well, I've been here for 8.5 years. So I feel like I know the whole town because like somebody who I would have treated 4 years ago and then I'm treating them again now, that
Yeah,
kind
they
of
come
thing.
back.
Yeah, that's the beauty. And that's another thing too. Well, it depends on what you want, because like if in emergency medicine is good, depending on what you like. But one thing too, like a lot of times people feel like, oh, they keep switching jobs and so on. But I've realized, and I've thought to myself about it and realized that when you keep switching jobs, nobody gets to really know you properly. They don't get to know your standards and see, your work ethic and so on. Or maybe they can, but I don't know, like just being here for 8.5 years, like, and just, people get to know you and realize, your skills and so on and so forth. And so, yeah, it's like, I don't know, I'm glad that I've been here for 8.5 years, and I wouldn't move. Like I don't have any interest in leaving, unless, who knows what the future holds. But like, because I've developed this relationship. I know all my colleagues, all the other doctors, surgeons, orthopedics, gen, surge, everybody, medicine. And so, when you stay in a place, you get to develop relationships, and everybody kind of knows, how you are and things like that. And it's pretty good compared to if like you keep moving every 2 years, you keep changing jobs, and like nobody's sure, like and nobody's sure about
Yeah.
you.
Yeah, that's
Yeah.
definitely true.
Yeah.
Yeah.
Mm-hmm. So
Wow.
anything else?
Yeah, I don't want to take up too much of your time, but this has been really great. I really appreciate you taking the time out of your super busy day.
Sure.
Yeah, it's great to hear from someone who's just so passionate and still loves what they do, especially nowadays. I think we hear more about like the negative and
Yeah.
people getting burnt out. So it's really refreshing to see
Yes.
this kind of energy.
Yes. It's life is still good as a physician once you know that that's what you like.
Yeah,
Yeah,
that's great. That's
it's
good to
it's
hear.
good. It's good. And sometimes it might take you a while to find the fit in terms of the group you work with. Because maybe I'm just lucky. Like, this is Mississippi, and Southern hospitality is a real thing. Like, people are really nice here compared. I mean, I worked in New York and New Jersey, and I can appreciate more warmth, here, compared to like New York and New Jersey. I mean, New
Yeah,
York and New Jersey were okay, but these people in Mississippi are really warm. Yeah.
that's nice. Yeah.
So that's good. It might take you a while. Like, I liked Antigua as well. I'm from Antigua, and I just love the people who I worked with and so on and so forth. But just for me, and just not being able to just use the knowledge, so there are different reasons why you have to leave sometimes, but I've always gotten along with everybody who I've worked with anywhere I've worked, to be honest. So, and maybe because again, like, I just love it. And at the end of the day, my whole thing, again, I tell the resident, I'm like, it's not about all the other people, it's about the patient, the individual you're trying to take care of. It's about them at the end of the day and nobody else. Mm-hmm.
Yeah, definitely.
Yeah. So
Yeah.
yeah, well, yeah. I had fun talking with you.
Oh, that's good. Yeah, thank you
Yeah.
so much
I
again.
hope, I wish you all the best. You can email me depending, when time comes in, you can email me, and probably email me to the one that I replied to you from a couple days ago.
Okay,
Because the
yeah.
other one, I almost didn't see the other one for whatever reason, but yeah.
Okay,
So, yeah.
great. Thank you
Hey,
so
I'm on
much.
social media, so you can always message me on social media as well.
Oh, cool. Oh, yeah, I was looking at your Instagram right
Yeah,
before this. I'll
yeah,
I'll
yeah,
follow.
yeah.
Yeah.
Yeah, all right, Heather. Well, all the best with everything, and just
Thank
work hard,
you.
and keep taking care of those patients. And yeah,
Yeah. Thank you so much. I
you're
really
welcome.
appreciate it.
All right, bye bye.
Bye.